The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
COVID-19 is not gone and certainly not forgotten, even if we'd all like that to be the case. So as Ontario seems to be marching ever closer to a new normal, tonight we'll look ahead at what the future of COVID might entail. First, with a new strain in town, we'll find out if it's got the same bite that Omicron did. Then, Nam Kiwanuka probes what new vaccine technology has to offer to keep the pandemic in check. It's Thursday, March 24th, and that's ahead on the agenda. COVID-19 hasn't just arrived as one virus, but in waves with successive variants. Omicron was the latest and most virulent, but now yet another strain is making its way into our midst. With us now to explain, let's welcome in Guelph, Ontario, T. Ryan Gregory, evolutionary biologist, professor and chair of the Department of Integrative Biology at the University of Guelph. And we are delighted to welcome you to our airwaves. Ryan, how are you doing tonight?
I'm doing well, thank you.
Okay, let's start off with the latest strain, as it's called, BA, I don't know, is it .2 or .2, or how do you describe it?
I've been saying BA.2, but you're probably going to be able to be understood whichever one you use.
Okay, what is it?
It is a subvariant, it's actually being called, of the Omicron variant. So the one that we are most accustomed to was BA.1. And these are divergent, they're related, but they're actually quite different genetically. And BA.2 is the one that is now increasing in frequency in various parts of the world, and including in North America, where it's gaining traction.
What makes it a subvariant as opposed to its own thing?
Well, this is something that I think we wonder about, and maybe best put to those who make the designation. But there are certainly enough differences in BA.1 versus BA.2 that in some ways it could be given its own designation. I've actually been pretty interested in what the consequence would be if it had its own name. So we tend to think of it all as Omicron, BA.1, BA.2 as all subvariants of Omicron. And so we talk about a prolonging of the Omicron wave, for example. But if this had its own designation, the next would be pi, or because everyone loves pi, they might skip to rho. If it had its own name and we were talking about the pi wave rather than a prolonging of the Omicron wave, would we think about it differently? It's, I believe the kinds of criteria that are used have to do with the specific biology of the variants, and it is similar to BA.1 in that regard, but genetically it's quite distinct.
In what way?
So what we do from an evolutionary standpoint is make use of the genome sequence data. And one particularly fascinating aspect of this pandemic is we have the accumulation of large amounts of genomic data basically coming in real time, which we haven't had in past pandemics, obviously. And that lets us track the genetic divergences of different lineages within the overall SARS-CoV-2 viral group. And in the case of Omicron, unlike in some of the other variants of concern that we've seen, there's a fairly deep divergence, meaning that there's a large number of mutations that separate the sequence of BA.1 and BA.2. Some have argued that it is about as different, BA.1 and BA.2 are about as different from each other as some of the other variants of concern were from each other. So it could warrant its own designation on a genetic divergence kind of basis.
In terms of the symptoms you will experience, though, does it manifest differently?
I think what we're finding out with SARS-CoV-2 and COVID-19, this pandemic, is we don't really know exactly how it's going to manifest in different people, different age groups, and also with different variants. So we keep hearing of new and changing symptoms. Sometimes they are fairly consistent. So for example, you might have runny nose, or you might have flu-like symptoms. In other cases, for example, with Omicron and BA.2, we're not hearing about symptoms like loss of taste and smell. The same, you may recall, at the beginning of the pandemic, that was sort of a big indicator was loss of taste and smell. That seems not to be the case as much now. More recently, I've seen reports of gastrointestinal impacts of infection that may be indicative of BA.2 and might be misinterpreted as something else when in fact it is a BA.2 infection. So it seems to be a changing landscape. And one thing we do know about this particular virus is that although it's transmitted through respiratory mechanisms, it affects a large number of systems in the body. And so that can manifest in different ways, as I say, in different people, and depending on the variant. So it's hard to say what exactly is going to be the suite of symptoms in any particular variant.
Okay, I'm going to confess here, this is a pretty nerdy follow-up question, but the acronyms kind of fascinate me here. COVID, of course, coronavirus disease, SARS, severe acute respiratory syndrome. BA, what's that stand for?
I'm not actually sure how they designate these, and these get used in different sources will use different designations. So there's one of the genome databases uses very different designations. So it's 21L and 21K, and so on. And so that's one I would have to defer to the virologists and the experts at the World Health Organization on how they're actually coming up with all these different names.
Do you think they do it just to confuse us?
No, I don't think so. I think it's the best attempt to try and keep track of a very rapidly evolving virus that is diversifying extremely rapidly, and that comes in these successive waves of new variants. So I think just trying to keep track of that, there aren't enough letters in the alphabet to cover every single potential variant.
Even if you use English and Greek. Anyway, I was going to say, even if you go English and Greek, but I'm getting way off the path here, so let me get back on the path. We're having a great debate in the province these days about whether or not we're taking off the protocols too quickly before we ought to be. Obviously, some people want us to try to get back to quote-unquote normal right away. Others say, no, with March break and so on, we shouldn't be doing this yet. We should wait a while before mask mandates go, et cetera, et cetera. I want to get your sense about how concerned you are about the restrictions being removed as we are suddenly encountering this new subvariant.
Well, I think what we've seen through probably 5, maybe into the 6th wave now, is that an overly optimistic decision on removing protections, and I actually prefer the term protections than restrictions. Removal of those protections is not always the wisest thing to do just because cases are coming down or hospitalizations are coming down. The nature of a pandemic that comes in waves is that it can go back up. And so sometimes we seem to look at numbers and say, okay, so the case rates are falling, let's remove those protections, get back to quote normal. And then we see a subsequent wave coming. So in the case of Omicron, we had what many described as initially projected to be a mild variant. I don't think that's been borne out. It's certainly not in the overall impacts on hospitalizations and deaths and so on around the world. And it ran rampant. And so what we're seeing is that the cases, hospitalizations, and so on are coming down, but they're essentially still quite high relative to where we've been at previous points in the pandemic. So we've kind of adjusted our expectation for what's an okay level of hospitalization or case rates. We're also starting to see examples of wastewater signal is increasing across parts of the province. We're seeing other worrying signs about the increase in the frequency of BA.2 over BA.1, and we've seen in Europe and other places where that has led to major upticks in case rates and hospitalizations again. So I would be wary of just looking at numbers of cases or hospitalizations and taking a downward trend, even to a fairly low level relative to the peak, as the right time to start removing restrictions or protections, as I say. Mm-hmm. The other thing to bear in mind is we are setting up conditions for future variants to evolve while we still have widespread circulation of the virus. So this is, as I said, a virus that is evolving quite rapidly. It's got a very high mutation rate. It diversifies quickly. Many of the mutations that we see in the Omicron variant and subvariants relate specifically to the spike protein, which is involved in its ability to invade cells. So it is evolving very quickly, and new variants can take various forms, can have different symptoms, as we talked about, have different transmission rates, different severities, and it's somewhat unpredictable. But what we do know is if you have a lot of viruses out there circulating and replicating, lots of copies being made, lots of errors will be made, and that's where you get new variants, is through these errors in copying of the virus. So the more you have out there, the more it's being transmitted, the more easily it can find new hosts, the more likely you are to get additional variants evolving and spreading.
No, I take your point on all that, but to be sure, there are places in the world right now where this is really out of control. The numbers out of Hong Kong, for example, are absolutely frightening. But I just want to clarify, would you agree that in the province of Ontario, at least under Omicron, regardless of variant and subvariant, this one's a lot less fatal than its predecessors? That's fair to say, isn't it?
So there's two really important aspects to the impacts of a virus. So one is the transmissibility, that is how easily it moves from one host to another. There's various components that can go into that. So mode of transmission, is it transmitted in smaller aerosolized particles that linger in the air longer? Does it move a longer distance? Are there higher numbers of copies of the virus in the lungs of an infected person such that they're transmitting more copies out into the environment? Is it better at getting into the respiratory tract and attacking cells within a new host, and so on? So transmissibility is essentially the capacity of a variant or strain, if you will, to move from one host to the next. Virulence is a measure of basically how much damage it does to the host once they're infected. And Omicron was discussed primarily in terms of mildness with regard to its severity or its virulence, so that on a per infection basis, the idea was that it was doing less damage to hosts. So you were less likely to end up in the hospital, less likely to suffer severe respiratory symptoms and so on with an Omicron infection than, say, with Delta, which was particularly damaging. However, Omicron had much higher transmission rates. And you can have, at the level of the entire population, much more severe outcomes if the transmission rate swamps out a lower per case virulence. So if you've got a lot more cases out there, even if they're individually likely to be less severe, they just get swamped out by the sheer numbers. And so we did see very high levels of hospitalization, including in some demographics where we hadn't seen it before, in younger age groups and so on under Omicron. And you're seeing some of that happening elsewhere around the world too. So mild relative to Delta, it may be. However, transmissibility is much higher, and that can translate into pretty serious impacts on the medical system, on number of hospitalizations and so on. The other thing is that it's difficult in some ways to say whether a particular variant is less virulent or more mild on infection when other things have changed. So, for example, we have in Ontario and in various parts of the world quite good vaccination coverage, at least with 2 doses.
Yes.
It does look like Omicron has had the capacity to undergo what are called breakthrough infections, so basically getting around immunity. It also seems that BA.2 can reinfect, and potentially including people who have had BA.1. So reinfection would also change that dynamic. But we have a population now that is much more protected than it was, say, under Delta or some of the previous variants. And so is it actually less damaging on a per infection basis if you were to compare Omicron with original strain that we saw basically spreading around in early 2020? Would it be less virulent on that level? I don't know that that's clear, but it's had a smaller impact on a per infection basis, in part because there's been vaccination. We have better treatment options and detection options and all that sort of stuff. So we're able to mitigate the severe impacts better, even if transmissibility is higher.
Well, let me see if I can just sort of follow the thread here of this next question, because, okay, 90% of us in this province have had one shot. And of course, that one shot was not specifically designed with BA.2 in mind, or BA.1, or Omicron at all, actually. And kids, the youngest kids among us, have not been required at any point to get a shot yet. I guess I'm wondering now, particularly with the mask mandates off, are we going to see a spike in cases because of all of that among the youngest among us?
Well, so we should probably be clear that last I looked, the 6 to 11-year-olds were somewhere around 50% vaccinated, and they have access to those vaccines. Under 5 still can't get vaccinated. So right. We still have a significantly unprotected group based on age in that regard. We also know that the immunity that was provided by 2 doses is waning, and that the Omicron variant is capable of breakthrough infections and reinfections, as I said. So what 2 doses, and better yet 3 doses with a booster, does is provides reasonable protection against severe impacts. It doesn't necessarily stop the transmissibility. So overall, though, it does seem that there is an age effect in terms of severity, and it's not generally kids that are getting the most sick from the direct impacts of a COVID infection. So they're not, I don't want to downplay the fact that there are many children ending up in hospitals in Ontario and around the world, but it's not the same level of severity that we see in some of the older groups. But there are still concerns about kids becoming infected, especially when they're not vaccinated. For example, very young kids. So they may have pre-existing conditions. They may have siblings who have pre-existing conditions. They may have parents who are immunocompromised. And if you have school-age children, you'll know that not just COVID, but diseases generally move around from household to household via kids at school. I mean, I don't think I ever got as sick as often as when my son started daycare. So there are these, this trading effect of viruses at places where kids congregate. So it's not just them getting sick. And then the other big piece that seems to be overlooked far more than I think it should is long COVID.
Right.
So this is a virus that infects, the respiratory tract initially, and that's where we tend to think of when we talk about severe acute effects. Are you ending up on a ventilator? Are you ending up in the hospital because you can't breathe? But the way that this virus attacks and infiltrates cells is such that it can access a number of different tissues, and it can have impacts on a number of different systems. So I've heard it described as, it's really more of a vascular disease, or it's an inflammatory disease, or it's a disease that can impact the circulatory system, the heart, blood vessels. It can get into reproductive tissue, the brain. So what I worry about with kids, my own kids included, is a little bit less that they are going to individually become severely ill with the initial infection, but rather that they will be transmitting it to those who have vulnerable members in their family, or that they will be susceptible to long COVID, which is of unknown connection to severity of the original infection and whether you are more likely to get it or less on reinfection and so on. We just don't know. And I think we need to be taking that risk very seriously.
Okay, Ryan, I got 30 seconds left to ask you one more question, which is, as we hopefully inch our way towards some kind of endemic condition of COVID, do you believe it is inevitable that as the variants and subvariants change, they're actually going to become less severe as we move along?
I think that's probably one of the biggest myths about how pathogens evolve, is that they inevitably become less severe. The notion, I think, is that in order to continue being transmitted, they have to be less damaging to hosts. But that's really not necessarily the case. And it's certainly not the case in a virus that can reinfect, that can escape immunity, that has severe symptoms show up significantly later than the transmissibility period. So it's certainly not a guarantee. All pandemics end eventually. This one will as well. It most likely will come to some stable level of infection in the population. We might have things like seasonal vaccination like we do with flu and so on. But it's really important to bear in mind 2 major things with this. One is there's no guarantee that any particular new variant is going to be less virulent. It will probably be more transmissible because that's how it will spread around the world, but it may or may not be less virulent. That's number one. The other is that endemic doesn't automatically mean harmless or mild. Malaria is endemic in parts of the world. Tuberculosis is endemic in parts of the world. Measles is endemic in parts of the world. And those three diseases together kill about 2 million people a year. So endemic doesn't mean that we don't have to worry about it anymore. It means that we can't essentially get rid of it, and it persists in a relatively stable frequency in the population. So how do you live with COVID? It's not by doing nothing. It's by improving ventilation. It's by wearing masks if you're feeling ill. It's by getting vaccination rates up and having more tailored vaccination rates. And honestly, it's vaccine equity around the world. So where we're seeing new variants arise is where there's high transmission rates. Where there's high transmission and infection rates is where vaccination has not been at the same level. And that's in many ways due to access. So we really need to take this as a global problem. We really need to look at equity of vaccination. We need to look at long-term mitigation strategies. And frankly, if we improve ventilation and filtration in buildings, that's going to be good for a number of different things.
Boy, I was really hoping you'd leave this on a more uplifting note, but I guess I should thank you and appreciate that you're keeping it real here. So, T. Ryan Gregory, University of Guelph, we're grateful for your time tonight on TVO. Many thanks.
My pleasure.
When the first COVID-19 vaccines became available, Canadians rushed to get them. Uptake for boosters has been a bit slower, and there is still a small number of people that are vaccine hesitant. Could new technologies and updates on what's available raise vaccination rates and keep the pandemic from resurging? Let's ask in Thorold, Ontario, Dr. Mustafa Hirji, Acting Medical Officer of Health for Niagara Region. In Hamilton, Ontario, Don Bowdish, immunologist and professor in the Department of Medicine at McMaster University. Matthew Miller, professor of biochemistry and biomedical sciences at McMaster University. And in Ontario's capital city, Omar Khan, a professor of biomedical engineering and immunology at the University of Toronto. Hi, everybody.
Hello.
Looking forward to this discussion and to learn more about what's happening in the world of vaccines. Dr. Hirji, I want to start with you. The uptake of boosters has really slowed down. What percentages are we seeing across the province now?
Yeah, so if you're taking all ages 0 and up, we've got about half of the population vaccinated with that third dose. If we're looking at the 18 plus age group, which is really the group where that third dose is really recommended, it's only at around 60%, which obviously isn't as high as we would like. The other key thing about it is that it really varies by our ages. If you're looking at the 70 and up population, the population at most risk of having severe outcomes, being hospitalized, unfortunately, perhaps even passing away, it's actually quite good in that group. It's well over 90%. But it starts to progressively go downwards as you go through the ages. And when you get down to the 20-year-olds, it's only maybe around 30% or a little bit above that right now. So there's particularly a lot of work for younger people to help them see the importance of them getting vaccinated, that even if it's not necessarily for them, it's hopefully to make sure that they're not spreading COVID-19 to some more vulnerable people around them.
Dr. Hirji, when the vaccines first became available, everybody was kind of like, get the first vaccine that that is available to your age group. And I remember being online trying to book my vaccine. It was kind of like people were booking tickets for like the concert in town, but it was really important for people to get vaccinated. It seems like it's changed when we do talk about boosters. What's your explanation for the low uptake?
Yeah, so, it's hard to necessarily say with a lot of confidence because I haven't seen any good polling on this yet. And I'd really like to get the direct information from the people who aren't getting vaccinated. The people we see in our vaccine clinics are obviously the people choosing to be vaccinated, so we're not necessarily seeing from the other side. But there's a few thoughts I have here. You've actually just highlighted one where you've used the language of a booster dose, and I think that's actually probably not the right framing anymore. A booster dose implies that you've got your vaccine series, you're done, and then this is, increasing your protection a little bit. And I think that really speaks to people maybe who feel more vulnerable and feel that this is something optional that you do if you maybe think you need a bit more protection. And that's, I think, not the case anymore. With the Omicron variant, you really do need 3 doses to get reasonably good protection against COVID-19. And I think we should really be reframing that fully vaccinated now means actually 3 doses, and that this is a 3-dose vaccine series. And I think that framing might help really get people in the mindset that they haven't finished getting vaccinated, they're not fully vaccinated, as the language goes, with 2 doses, but they actually need to get the 3 doses.
And Omar, just to build on what Dr.
Yeah.
Hirji was just saying, we've had various variants since the vaccines came out. Are the vaccines we are now using still effective against the new mutated variants?
For the original vaccines, they did a great job at fighting off the virus that they were originally designed for. But with high case numbers, there was viral evolution, because every replication event is an opportunity for a mutation. And the problem is that the antibodies that we were developing weren't as good at recognizing these mutated spike proteins, which is fine, that happens. But so the ability to recognize it went down a bit. So you do have good protection, you have long-lasting protection. It's just now you're asking your antibodies to see and recognize something that looks a bit different. So in framing it like that, when we boost people, we can bring back up your antibody levels to a high enough level where even if they are slightly less effective, there's more of them. So you can kind of help compensate for that. And that's what we call recall. So we try to induce recall. And otherwise, if you have antibodies that just don't have a good shot at recognizing the new mutated versions, then your immune system would likely try to restart that process and develop brand new antibodies for it instead of using the original ones that are potentially less effective. So this is part of the challenge. And having a booster is a great stopgap while we wait for more updated vaccines to kind of tide us over.
And Matthew, I guess this is where the conversation could lead to what's being done right now, this idea of redesigning the vaccines that we already have. Why might they be more effective if they were to be redesigned?
Well, the situation we're in right now, in many ways, is analogous to the situation that we're used to annually with seasonal influenza. As my colleague just described, over the course of the past 2 years since the pandemic started, the very high global case rates have allowed this virus to evolve and mutate in such a way that it's no longer recognized as well by the immune responses we generated via vaccination. And so one way to improve the quality of that immune response is to update our current vaccines so that they're a closer match to the viruses that are actually causing infections now.
And Don, how would that work? Would we have to go from starting from scratch, or do we need to do full clinical trials as well?
It's a great question. We've learned a lot about protective immune responses to this virus. And so some of that learning we've been able to implement to next generation vaccines. And in fact, my very clever colleague, Matthew, has done some of that work in redesigning an inhaled vaccine that triggers different parts of the immune system, the cellular response as opposed to the antibody response. So in many ways, we have a little bit more knowledge about features that are more resistant to the virus changing and mutating. And by harnessing immune responses to those conserved elements, we may get more or better cross-variant protection. As for whether we need full clinical trials, well, that really depends on whether we understand what we call the immune correlate of protection is. So if we could say your antibodies have to be here to be protected, or you need so many T cells, then we could use that as a proxy measure instead of waiting for people to get naturally infected. Clinical trials take a lot longer if there's less infection circulating and we have to wait for people to be infected. So understanding these immune correlates of protection gives us a stopgap that we can make some inferences about protection without waiting for a really long period of time for people to get naturally infected in the trials.
Matthew, Don mentioned inhaled vaccines. We're going to talk about that in a few moments, but I wanted to give the time to Omar. I saw, Omar, you wanted to respond to something?
Yeah, I think for a lot of these vaccine technologies, for example, the mRNA technologies, they're designed to be platforms where they can be easily updated. What this means is that most of the vaccine stays the same. The only thing that's being updated is the mRNA, so the sequence of the mRNA. But everything else on how the nanoparticle is made remains the same. And that can potentially speed up the rate at which we can get vaccines out to people. But this is something new, and regulatory bodies have to come to terms with this and understand, how do you safely regulate this new type of technology that can be so rapidly uptaken and rapidly updated? So this is part of the other side of it when we think about the development of the actual vaccine and what it takes to say that this is pretty much the same thing. It's only slightly updated. So perhaps you don't have to do a full 3-phase clinical trial. Maybe we just need enough to show that there is safety, and coupled with the right correlates of protection, then this can be approved. So that's an active thing that's happening now on the other side from the regulatory body, because no regulatory agency wants to approve something that can potentially hurt the citizens of their country, right? So this is an important question that everyone has to figure out. How do we safely update these things quickly?
And I guess the quickly part is important because we're probably waiting for, it gives more time for new variants to come up as well. Matthew, I want to come to you. Health Canada approved the Nuvaxovid vaccine back in mid-February. What makes it different from the other vaccines on the market right now?
Well, the Novavax vaccine uses
I knew I said it wrong. The names of these vaccines, it's like, I knew I said it wrong. I tried. But go ahead. Sorry, Matthew.
No problem. No problem at all. Yeah, the Novavax vaccine uses sort of more conventional vaccine technology than some of the vaccines that were first approved for COVID-19. While mRNA vaccines and viral vectored vaccines have been studied for decades, these were really the first examples of those types of vaccines that were rolled out at a global level. The Novavax vaccine, instead of asking our cells to make the spike protein of coronavirus, which our immune system then responds to, in the Novavax vaccine, the spike protein is part of the vaccine and is delivered directly to our immune system. And this is similar to many other vaccines that we're used to and that have been on the market for a long time, including things like the vaccine against shingles. And as a result of that, I think there's some hope that vaccines like Novavax may be appealing to people who are nervous about some of these perceived newer vaccine technologies, and thereby increase vaccine uptake for those individuals.
When do you think health units will be administering the Novavax vaccine?
My expectation is that they could start administering that vaccine almost immediately. I don't know exactly what the procurement numbers are like right now at local health units, but I see no reason why there should be any delay for people who might want to receive that vaccine at this point.
Dr. Hirji?
Yeah, speaking from the perspective of the local public health unit, what we're actually waiting on right now is actually for the vaccines to arrive in Canada. The federal government, of course, does the procurement, sends the vaccines to the provinces and then down to us at the local level, and we're still waiting for the federal government to actually receive the vaccine. Our understanding is it's supposed to arrive by the end of the month. So, my hope is within the next couple of weeks, we can hopefully start to administer it. And actually, just very quickly, Nam, going back, you were correct. Nuvaxovid is the brand name of the vaccine. Novavax is the company that helped develop the vaccine. So when you say the Novavax vaccine or what you said, Novavaxovid, it's usually just two different names for the same thing.
I'm very excited about that because some of these names. Omar, thank you very much, Dr. Hirji. Omar, another recently approved vaccine is a plant-based and homegrown Covivax. I think I said that right. It's by Medigaco. It's tied to the tobacco industry. Do you think that devalues it in any way?
From a scientific point of view, the vaccine does look like it works and it is safe and effective. And again, speaking from the engineering logistics point of view, things like the Novavax vaccine and the Medicago vaccine are important tools that we need for better global distribution. Both of these vaccines don't need to be frozen to be stored, and they can really help with distribution, especially in places in the world that just don't have that cold chain of storage. And this is an important step in getting more people vaccinated, because the more people are vaccinated, the faster they clear infections, the less viral replication events we have, and we can really help slow down viral mutations. And that keeps our vaccines current longer. Now, the challenge with this tie to the tobacco industry is partly because of the World Health Organization. So not every country in the world is as fortunate as Canada. We have the resources And we can fund something like Health Canada. Health Canada can look at a producer's documents, and they can look at all the clinical data and make the call saying that we've reviewed this data, this vaccine is safe to use on our citizens. Because not every country has this, this level of resources to do that. They rely on the World Health Organization endorsing something. And if the World Health Organization can't do that, then that may lead to some barriers for that uptake. And the WHO can't really endorse something that's tied to the tobacco industry because they have a stance against that because it can cause cancer and hurt people, and they don't want to be tied to that. So this is the tricky part. So from just purely scientific point of view, it's a great tool. It'll help with global distribution. It'll help give people protection. It'll help slow down viral evolution. Great. But there's that really important other component of how do we address this tie? And whether that'll be a one-off exception or something else, I'm not sure. But really, other countries do look to the World Health Organization for the cue on whether or not this is okay to use.
And Dawn, I saw you nodding as well.
Yeah, I think as Canadians, we have not been very responsible in recognizing global challenges with vaccine distribution. And the Omicron variant was a painful reminder that nobody's safe until everybody's safe. And so I think it behooves us to think about things like novel technologies that are amenable to production in the global south. The cold chain issue is one that has been on the vaccine manufacturers' minds for decades. And so I think moving forward, one of my big learnings was that we have to have a more global perspective to vaccine development, including sharing the technologies and also helping train people. It is not a matter of just creating a vaccine and opening a factory. The amount of learning and training and expertise that's required to do these sorts of things needs to be something that we're exporting to the rest of the world. And I really hope this will be a turning point in our commitment to global distribution of these vaccines.
And Matthew, Dawn mentioned earlier that your team is developing a vaccine that can be inhaled. Can you explain to us how that would work?
Yeah, absolutely. So having come from a long background in the influenza field, we recognized very early on that SARS-CoV-2, the virus that causes COVID-19, is a virus that was going to continue to evolve and mutate, which would challenge the effectiveness of our current vaccines. This motivated us to take a different approach and to try and generate a vaccine that would be less susceptible to having its effectiveness decrease in light of viral mutations or the emergence of variants. In order to do that, we designed a vaccine that contains multiple components of the virus. All current generation vaccines are targeted against the spike protein only. And that's a challenge because that's a part of the virus that mutates very rapidly in the context of variants. By including more viral targets and focusing especially on viral targets that are unable to mutate as much, we've been able to design a vaccine that's in preclinical studies been completely protective against variants. Another important difference of our vaccine is that instead of being injected, it's inhaled. So our propensity to inject vaccines really harkens back to the days of sort of Edward Jenner and the development of smallpox vaccines, where we used this process called scarification, which was essentially sort of scratching old smallpox material into the arm in order to generate immunity. And that makes a lot of sense for pathogens that cause infections in our blood, for example, because injected vaccines create great immunity throughout our whole bodies. What they don't do so well, though, is create strong immunity in our lungs and respiratory tract, which is, of course, where viruses like SARS-CoV-2 and influenza infect us. So to overcome that challenge, our vaccine was designed so that it could be delivered via inhalation. And as the vaccine is inhaled, it creates a very different kind of immune system in our lungs that's much more protective, while at the same time still generating that systemic immunity that spreads throughout our whole body. So the combination of targeting the virus in a different way so that we're not constantly chasing its evolution, and refocusing the immune response to our respiratory tract, which is, of course, where we're infected, is sort of the strategy we've taken to get out in front of the virus so that we're not constantly having to update our vaccines perpetually going forward.
And just to follow up, that vaccine, you actually inhale it by mouth. We have vaccines where you can intranasal through your nose.
Yes.
Are inhaled vaccines better options than intranasal vaccines as boosters?
I think they are. So intranasal vaccines have been approved in the past. Most people are probably familiar with the intranasal influenza vaccine, which is called Flumist. The challenge with intranasal delivery is that that spray remains localized mostly in the upper respiratory tract, primarily the nose and throat. The benefit of inhalation through the mouth is that the vaccine is delivered deep into the lungs. And we know that in the context of COVID-19 and influenza for that matter, infections in the lower lungs is what makes us severely ill. Upper respiratory tract infections tend to be more mild. And so by inhaling the vaccine, we're able to stimulate that protective immunity in not only the upper respiratory tract, but also the lower respiratory tract, which we anticipate will provide much stronger protection against severe outcomes.
That makes sense. Kind of like an inhaler when you have asthma, right? But
Exactly
Omar,
like that.
Okay, Omar, you wanted to say something? Go ahead.
Yeah, I think this is a great opportunity because we're looking at different forms of antibodies that are in the blood and antibodies that are in the mucosal area. And this is also a great opportunity to remind folks that there are other forms and other parts of your immune system that are actively working all the time. And I think also, in addition to this wonderful opportunity we have here, we should also be thinking about cellular immunity. These are special cells of your immune system that actually remove cells in your body that are infected. And I think cellular immunity plays a big role in clearing infections in general. So even with the help of antibodies, this completely different arm of the immune system can really make a big difference. So as we move ahead with new vaccine technologies, I think there's a wonderful opportunity for us to then start leveraging all these other components of the immune system because they are always in play no matter what. And if we can help harness that power a bit more, then we can not only take advantage of inhalable vaccines and injectable vaccines, but there's so many more opportunities to give people really long-term, durable, and robust immune responses.
And we can't underestimate how many people don't like needles, especially like with kids and stuff. Dawn?
I was just going to comment on that. For a number of the vaccine hesitant, the fact of being injected is something that really threatens bodily autonomy, and they feel much more warmly about things that we inhale. Many people inhale many different things and feel much more comfortable with that. So I think this is also a way of addressing hesitancy. And the needle phobia is not to be laughed at. I mean, certainly parents who don't have Flumist available to them as an intranasal delivery will choose not to vaccinate a needle hesitant child. So these different technologies help deal with the psychosocial aspect of vaccination and may be more palatable to people who have or feel uncomfortable with the injection model of vaccine delivery.
Dr. Hirji?
Yeah, and I just wanted to basically reinforce what Dawn's saying, but saying that this is actually an issue with adults as well. I don't remember what the numbers are from the surveys that have been done, but it's a pretty significantly large double-digit % of people who have at least some, hesitation about getting vaccines and getting injections. And while it may not ultimately stop people from getting vaccinated, often maybe it delays them, it causes them not to get it as early as possible. And for some people, maybe they don't get it at all. And so it's not just an issue for kids. I think it's really an issue for all people. And other means of delivery of vaccines that are more palatable for people can only help.
And Dr. Hirji, to follow up with you, do you believe these new vaccine options will really make a difference when it comes to booster uptake?
I hope they will. I think the impact is probably going to be fairly small. I look at, in Canada, where in Ontario, even we have close to 90% of people got that injected 2 doses of vaccines. people are ultimately willing probably to get it, and there's probably only a relatively smaller group who is going to be swayed by some of these new technologies or even some of the newer vaccines we talked about earlier. I think it's going to be particularly helpful, though, down the road if there's, say, an additional dose of this vaccine we need to get, or perhaps, a new pathogen comes on the scene and we develop a vaccine at that point, to have these tools available so that we can have a vaccine that hopefully gets much quicker uptake at that point.
Matthew?
We spoke a little bit earlier about some of the challenges now with upping the proportion of the population that has received that third booster dose. And I think that some of the data we're seeing at this point suggests that the perception that current generation vaccines are not doing as good a job at preventing illness overall, despite the fact that they are holding up extremely well against preventing severe disease, is one of the things that's made people who haven't received that third dose complacent. And so as we move forward, I think any updates that enhance the confidence of individuals that the vaccines are working even better, as well as vaccine technologies that prevent the need for regular boosters, will be really beneficial, because as we see in flu seasons historically, just the sort of inconvenience factor of having to be reboosted annually is a major challenge for rates of vaccine uptake. Many people are not vaccine hesitant or vaccine unwilling. They just have a hard time finding the time, to go to a pharmacy or doctor's office to get that shot. So anything we can do to make the vaccines more effective, I think, will be beneficial in increasing confidence and therefore acceptability. And of course, the less we have to vaccinate, the more convenient it becomes for people. And by virtue of that, the more compliance I think we'll see.
Well, Omar, how long into the future do you think we'll need to get boosters?
I think this is really tied to the global health problem. We can deal with the situation very locally, like we did in Canada, and see great reductions in the number of cases and hospitalizations. And then we'll get pulled back into the cycle because elsewhere in the world, there was too many replication events and we see a new variant. And this is part of the challenge. So whatever new technology we're coming up with, the most important thing we can do is distribute it, because that's the only way we can preserve its efficacy. And if we really want to break out of this cycle, we can't address it locally. We have to address it globally. And fortunately, we do know that other manufacturers like Pfizer and Moderna, they are working on a more Omicron-specific vaccine. Those are in trials. And perhaps in a few months, we'll see some more of that data. And if that does come out and it's effective against BA.2, perfect. But we really need to get that distributed around the world to make an impact and finally break us all out of this cycle, because I think part of this is fatigue. The fatigue of having to keep getting vaccinated, but then also the fatigue of how frequently do you need an update. And that's really anything to extend time between doses is phenomenal.
Dr. Hirji?
Yeah, I just really want to emphasize what Omar was saying, and actually I think Don alluded to it earlier. Omar started off our conversation by highlighting that every time in COVID infects someone, that's a replication event. It's an opportunity for that virus to mutate. And when the virus is spreading a lot, it is mutating a lot, and we end up with new variants. And until we really have high vaccine uptake around the world, we are going to probably see new variants emerge that come back and threaten us, and possibly need us to do new vaccines for people, additional doses of vaccines, which hits on all of those confidence issues that's been highlighted. In Canada, I mentioned we have 2 doses of vaccines, close to 90%. Globally, it's more about 56% was the last data I saw. In parts of the world, they're actually in the low double digits in terms of that. So there's a lot of work that I think we can do that is actually going to mean that we are protected long term, and then the process save a lot of lives around the world.
Matthew?
Yeah, and I just want to expand on those really insightful comments with what I hope is actually a hopeful message for viewers, which is that in comparison to influenza virus, the intrinsic rate that SARS-CoV-2 evolves at is much, much slower. The reason that we've seen such massive, rapid evolution of variants is indeed because of the huge numbers of global cases that we've seen. vaccine. So when we can get global cases under control, and those resemble something, for example, that we're more used to with influenza, the expectation is that the rate of evolution that we see with COVID-19 or SARS-CoV-2 should actually be much slower. And that in and of itself could reduce the rate at which we need boosters. And so I think it is so important that we get this situation under control globally, because it will considerably change the trajectory and rate at which we experience waves caused by new variants in the future.
Don, we throughout the pandemic, we were joking about how trying to book a vaccine was kind of like the Hunger Games. May the odds ever be in your favor. And this time around with boosters, I think we're obviously trying to do things differently. How can we best serve older adults and vulnerable people in our vaccine rollout moving forward?
Absolutely. I think so many of us who have older parents were online trying to get them vaccinated and sorted because a lot of the online systems that we were using were not really accessible. So one of the fundamental teachings of public health is you bring the public health measure to the people. You don't ask them to come to you. And I know certainly I've been very heavily involved in the long-term care sector, and getting the staff vaccinated was really, really challenging when we were asking them to take time off work and to go to a distance. So we need to really make sure that our vaccine strategies bring the measures to the people, and also that we're speaking to the specific concerns of specific populations. The concerns of older adults tend to be quite amenable to getting vaccinated if you can get them into the system. But there are racialized communities. A significant number of our unvaccinated right now are people who are new to the country, don't have good access to service. And again, we have to think globally and act locally. Any vulnerability is a vulnerability to us all. We need to make sure that we're bringing these measures to local homeless shelters, to people who will not have access or will not feel comfortable or don't have a family doctor. So, bringing the vaccines to the people is important, and building the trust. And in these low times that we have, when we have a little bit more time and we're not frantically vaccinating, we need to work on education, community building up leaders in those communities to be confident about what the vaccine can and cannot do, so they can speak in a way that really resonates with their community. Trust for these populations is absolutely enormous.
There is a perception that COVID is over. Mask mandates are done. Vaccine passports have been removed. People are traveling. Businesses and events are back to so-called normal. Offices are reopening. Do you worry that new vaccines might impact the desire or the need for people to get vaccinated because there's a feeling that this is no longer necessary or urgent? Dr. Hirchi, I'll start with you.
Yeah, no, I think that's absolutely a huge concern. And, when I look at some of the data right now in Ontario, we're seeing a very sharp increase in our wastewater data. In Niagara here, we've actually seen a doubling of patients who are being treated for COVID-19 in our hospital system over just the past 7 days, admittedly starting from a relatively low number, but nonetheless, it's a pretty significant increase. We've seen a doubling of the number of outbreaks we have in long-term care homes and retirement homes in the last week. Of course, that's an indication that probably more people are out and about, unfortunately, getting COVID-19 and then showing up to work or visiting a relative in a long-term care home. So I do think COVID-19 is actually on the rise again. And I think, unfortunately, we're not necessarily hearing that strong message from our governments anymore about the importance of continuing to maintain vigilance against COVID-19. I think they framed it that we're at a stage where we no longer want to have, mandated restrictions, and it's going to be now more voluntary on us, but they haven't necessarily followed that up with the strong, intense messaging that we need to continue practicing those voluntary measures. And I think in that silence, the signal, unfortunately, people are getting is measures are going away. So probably there's no longer much risk here. I don't need to worry about going out and getting that third dose. And unfortunately, I think people are going to be complacent, which is going to make us more vulnerable going forward. And I particularly worry about older people who are in those marginalized communities that Don was talking about, who, despite even maybe having their vaccines, are still vulnerable for getting severely ill. And I think it's important for the rest of us to still be practicing precautions, getting our vaccines, so we can make sure we're not passing infection on to them and putting them in harm.
And Omar?
Yeah, I think we also have to remember that a part of our population is still completely unvaccinated. So we have the children under 6. There are adorable little engines of viral evolution. So we are seeing data from places like Moderna that says their vaccines so far look effective and safe for children under 6. And as long as those get approved and continue to look safe, then that's going to be an important opportunity for us to get more equity into this, because now we'll have most of our population age groups protected. And again, the goal is to bring down the number of viral replication events. So that should be coming up, but that has to be kind of weighed in as well, because we do have this big, a part of our population that just have no opportunity to be vaccinated, even if they wanted to.
Dawn, I'm going to give you the last minute that we have. What would you say to someone who might be thinking it's best to wait for the next best vaccine instead of getting the options that we have right now?
Even if you don't feel that you're at risk of hospitalization and dying because you've had your 2 doses, don't forget that having COVID is associated with a lot of long-term health issues. People who've had COVID have long COVID, which is a long-lasting syndrome of many, many symptoms that can reduce a person's ability to work or to enjoy the activities of daily life. And vaccination protects against that. That 3 doses will make your Omicron infection shorter, less likely to be symptomatic, and protect you from that long-term health consequences. Your family needs you, your workplace needs you, your community needs you to be as healthy as you can be, and 3 doses will help you get there.
Thank you so much for taking some time to speak to us on this really fascinating topic and giving your insights. We really do appreciate all the work that you're doing for our communities. Thank you so much for your time.
You're welcome.
Thank you.
That is the agenda for Thursday, March 24th, 2022. A pact between the federal Liberals and the NDP came into effect this week. Tomorrow, what to make of that deal? I'm Nam Kiwanuka. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.